go ahead and change. Should I put this on a
Yeah.
slideshow?
Hmm.
There you go. So we've got little arrows. Good. All right. So yeah. So I'm going to say yes. Continue to share this PowerPoint window. Yes.
Yeah.
Thank you. There. So yeah. So welcome everybody online, and welcome to you guys here in the room. It's always a pleasure to come and talk to you. Um, again, my name is Chuck Griffis, and I've been a nurse for nearly 50 years now. Um, so why was I interested in nursing? So let's just kind of start with that. And so I was always interested in like chemistry and chemistry sets and stuff like that when I was a kid. My parents were always buying me that kind of stuff. I was watching all the medical programs, that I could find because I didn't know, it just always drew me. I don't know why. And then in high school, I actually started to volunteer at a local hospital in Lakeland, Florida, where I was growing up. And as soon as I was there, I just felt a kinship with everything. I just felt like, yeah, this is it. And at that point, I was only like 13, 14 years old, but I just really felt like this is where I'm going to be. So then in college, what happened was once I decided that I wanted to study nursing, I decided that the best way to really dive into everything, I had to have a part-time job, to help it make ends meet. So I went to work as a nursing assistant in an area emergency department at Tampa General Hospital. And and I thought if I can do this, I can do anything. And so doing that um, really opened my eyes to so many things because I really had an amazing mentor at that time.
Okay.
There you go. I had like an amazing mentor at that time. Um, and this wonderful nurse named Doris Foster sort of adopted me. She was everybody's grandmother. And so I wanted to share like a story to give you guys an idea of sort of how I learned. Well, I was going to nursing school, but I was also in this part-time nursing assistant work in the emergency department. My first day at work, maybe second or third day, somewhere along in there, I had never really done much with emergency patients, but because I'd been orienting as a nursing assistant. And back then there weren't any, organized nursing assistant programs to learn. You just kind of learned on the job, and then there was a job description of what you were supposed to do. So I knew whenever there was a cardiac arrest patient, I was supposed to do cardiac massage. Again, this is in the 70s. So this is just when American Heart was beginning to start to get all the American Heart and BLS standards put together. But I knew what I was supposed to do, but I'd never done it before. So our first patient that came in with a cardiac arrest, a code patient, um, came in and Miss Foster called me over and said, start doing cardiac massage. She showed me how to do it. And so I watched the doctors work for a while. And then after a while, I watched them do a lot of stuff and I would do cardiac massage when they told me to. But after a while, everything stopped. Nobody was doing anything and I was just standing there. And finally I asked Miss Foster, the doctor started leaving the room, and I said to Miss Foster, I said, well, how's the patient doing? Well, Miss Foster smiled and said, you really don't know, do you? And I said, no, I don't know what's going on. And she said, you probably should sit down. She said, but I just want to tell you, this patient has passed away. And now we have to take care of him because he could be our brother or our father or one of our children. And we need to take care of him. Even after he's passed away, he's still our nursing responsibility. So she showed me how to do postmortem care right on the spot. Showed me how to take care of the patient. And before we even started actually doing applying the shroud and that kind of thing, she brought the family in and spoke to the wife, along with the ER doctor, and was there supporting the wife and the children. And I got a chance to really see how nurses can work with people in the world, in these kinds of situations. It was very sad, but it was part of the nursing care. And I never forgot that. And I've shared that story with so many hundreds of my own students since then. But it really helped to set the stage for me and, the kind of nurse that I wanted to be. I wanted to be the kind of nurse that when something happened like that, I knew what to do and I could step up and actually do it. So anyway, I finished my nurse's training, and I went to work as a floor nurse on 5 East, Tampa General Hospital, which is a 1,000-bed general public hospital in Tampa, Florida, huge hospital and well known throughout Florida and the Southeastern United States as a leader. And I worked on the night shift on this floor, and I learned how to prioritize care. And one big way that I learned was I was the only RN. I had two LPNs and two nursing assistants working with me. One of the nursing assistants, Ruby, was the person. She was smart, she was fast, she knew how to prioritize, she knew exactly how to pass out assignments, she knew what the patients needed, and she knew what I needed as an RN to be doing. And I was just learning. I just graduated from school, and I had to pass out all these meds all night long and still watch over these patients and help with some of the treatments and things. And Ruby was the one that really helped me get organized. An aide, a nursing aide, a nursing assistant. And she was the person that I would go to whenever I had a question of, well, what should I do about Mr. So-and-so? His dressing has to be changed, but at the same time, I have to put an IV in Mr. So-and-so. And she's like, you do the IV first and let me in the LPN do the dressing. And I was like, okay, sure. But that's the way you learn so much in nursing is by the people that you work with and the situations you get into. And I remember one night in particular, Mr. Roy Stewart was one of our patients. He's passed away many, many years ago. And he had nasal cannula oxygen because he was a COPD patient. And his wife brought him a package of cigarettes. Mr. Stewart, of course, was not supposed to smoke at all because he had oxygen. So I smell some smoke. So I went in and poked my head in the door. This kid is in the middle of the night. And here he is. He's got this cigarette in his hands with this nasal cannula oxygen going. And every time he takes a puff on the cigarette, it's like a torch. And he throws the cigarette away from him and it promptly catches the curtain on fire. And being the calm, cool, collected, basically still student registered nurse that I was like, he's on fire. Thank God Ruby was right down the hallway. She ran up. There was a bucket of dirty mop water right outside the door. She grabbed the bucket and threw it on him to put him out. And then I pulled him out of the way. And then she grabbed the fire extinguisher and put the fire out. And she told me, you should know where this fire extinguisher is. Did you even look? And I was like, no. She said, well, in the future, you make sure you know where all your emergency equipment is and how it works because we depend on you in an emergency. And I felt like saying, no, Ruby, I depend on you in an emergency. But again, these lessons that you learn. And I learned, to be patient with the people I was working with because sometimes they had their own issues. Excuse me, have a sinus infection. But as long as I have enough cough drops, I'll be okay. And altogether, we did a great job for that year on nights on 5 East IC, 5 East on Tampa General. And I really learned a tremendous amount about how to prioritize, how to look at patients and decide who comes first, who comes next, how to delegate. Because that was another thing I didn't understand how to do. I thought I had to do all the dressing changes and everything myself, but the licensed practical nurses could do a lot of that. I just needed to tell them what needed to be done. So again, it was a great learning experience for me. So then a year later, a position became available in the emergency department. Well, I had been a nursing assistant in an emergency department, of course, like I said, when I worked my way through school. So I wanted to be a registered nurse. And so went down and went to work there as an ER nurse on 3 to 11. We had anywhere from 75 to 100 patients a shift, very busy trauma center, the only trauma center in Tampa. And so we had a lot of patients coming and going. And again, I learned a lot about medicine from the doctors I was working with because, of course, we would have emergencies where, the registered nurse would start the IV and start giving medications and order blood, order lab work, get the lab work back to the doctor, make sure the patient was safe with everything that we had given, had the monitor going, you had to watch the EKG, all of that stuff. And so there was a lot of nursing duty and a lot of interaction with the medical staff. We also had residents in training. But one of the biggest lessons I learned didn't really involve a critical care patient. One of the nurses that was working there, Donna Ellis, who I just saw 2 weeks ago in Tampa when we all got together, was a mentor for me. And I remember how kind she was with patients, how no matter what, she always had an extra minute to spend and listen to them. And we had a patient who came in who had been assaulted and was a drag queen, basically, had been assaulted on the boulevard and was brought in partially in drag, covered with blood, and having been beaten. And I remember Donna very specifically, hey, come on in, you guys.
Welcome.
I remember Donna very specifically telling the resident, I better not hear you make a disparaging remark to this patient. You understand me? This patient is as deserving of care as any other patient. I don't care what they look like, what they're dressed as, what their race is, what their status is. You take care of them like you do everybody else. Because the resident had already started making some smart ass remarks when she was like, I'm not having that. Now you get in that room and you behave like a doctor. I expect you, and I'll be watching you. And he was like, well, ma'am, yes, ma'am, Miss Ellis, no problem. And I was watching all this too, as a young nurse learning. And Donna made sure that this drag queen patient who'd been beaten up was cared for respectfully. She got him clothes to wear, made sure that he was dressed appropriately when he left. She kept the curtain pulled for privacy. And when he left the ER, she arranged for him to go out through the side door of the hospital, to be released to friends. And I never forgot that because I thought to myself, it's true. We take care of everybody that walks through the door exactly the same way as everybody else. And that was a big lesson for me. And in the meantime, of course, we're having emergencies going on too, and we're all running around. But I never forgot that it's always important to take the time to be there for your person, no matter who they are, to try to understand where they are in life and what you can offer them as their nurse, and that you're the nurse for everybody, everybody. And you figure that out as a nurse, what they need, and you provide it for them. So that was a wonderful lesson that I learned there. Again, during my time in the emergency department. In 1976, I moved up to the newly minted cardiac surgery intensive care unit at Tampa General Hospital. It was just starting. And as soon as the application went out for nurses to work there, I definitely applied. I was first in line because I love the idea of cardiac surgery, excuse me, and taking care of patients that had cardiac surgery. So I absolutely loved it. I was one of the nurses that opened up the unit. The cardiac surgeons um, trained us in all of the things that we needed to do to take care of these patients because Tampa General had never had a CSICU unit before. So the surgeons that were opening up the unit actually took us aside, us nurses, and trained us all on what every shift would need and what every patient would look like and how every patient's course would be, what to do and what not to do. And of course, they referred us to all the already present nursing guidelines for cardiac surgery patients to read up ourselves. And so we had a very good education. And then it was a very, very busy unit. We just worked night and day there. I started out on nights and then worked my way on to 3 to 11 and finally onto the day shift over the years and finally into a management position on the unit. And one of the main things that I really loved about the cardiac surgery ICU was all of the lines and the tubes. We had to learn about arterial lines, how you set up the machinery for them, how you monitor the tubing, how you make sure that everything's tightly put together, because if there's a leak, it could be catastrophic for the patient, how to make sure that it was zeroed and that it was on the appropriate scale so that we could monitor the blood pressure beat to beat. I learned to monitor blood loss in patients that were acutely postoperative from the cardiac surgery room, OR. And when the blood loss began to pick up, we had the standing orders to start administering blood, but we also had to use our nursing judgment about when we needed to call the surgeon because we felt like the patient was having an abnormal amount of blood loss, and the surgeon needed to come and check the patient to see if they needed to go back to the OR. So I learned a tremendous amount by working with all of those nurses, but also we really had a lot to do with the anesthesia service because the anesthesia service would bring our patients directly to us. They didn't go to the recovery room. They went to us directly for their recovery and then for their postoperative care. And so there was an amazing cadre of about 7 CRNAs and 2 physician anesthesiologists that specialized in doing heart surgery. And those CRNAs were amazing. They were just amazing. I mean, they were bringing the patient in, and every report they gave, they never missed a beat. They never missed anything the patient had or might need. They told me exactly what to watch for. If they needed to come back because the patient was having some kind of anesthesia-related problem, they knew immediately exactly what to do. And they were always so calm, cool, and collected. Like, we would have a patient, for example, arrest right out of the operating room, go into VF as soon as they got ventricular fibrillation, as soon as they arrived on the unit. The nurse anesthetist, cool as a cucumber, just took the paddles, fired up the paddles, said, start CPR. I've got the paddles ready. I'll tell you when to pause for a minute. put the electrode gel on and say, okay, out of my way. I'm going to shock on three. One, two, three, shocking now. Cheek. And I was just, and never break a sweat. Never break a sweat. Pulse rate still 72 a minute. And I was just like, wow, how do you do that? I wanted to be that person. So, so it was amazing working with them. And of course, I learned about anesthesia because they would bring us anesthetized patients still asleep from the OR directly to us, and we had to recover them and wake them up. Most of them were intubated, excuse me. And so they were on the ventilator, and we had to manage their ventilator care as well. So it was just an amazing training in physiology, pharmacology, and critical care. And I know I'm speaking for the critical care club, I think, for the school, maybe later on this month, maybe in January, actually in January, I think. So I can talk more in depth about the critical care aspects to them. But it was a great education for that. But I knew I wanted to be a CRNA, basically. I mean, I watched those people work and I just was amazed. So one evening, I had a patient who had had cardiac surgery and who had severe COPD and had been extubated and somehow had begun developing respiratory failure and some pneumonia, very common in COPD patients, despite the fact that we had him on antibiotics. And as he got developed more and more respiratory failure, it was obvious that he was going to need to be intubated because his all his blood gases were coming back worse and worse, and he was struggling to breathe. So one of the CRNAs came over to intubate him, and watching this person work with this patient that needed this intubation was a total education in itself because what the CRNA did was they took their time with the patient. The patient was very short of breath, but he was still alert enough to understand what was going on. And she sat there at his bedside and held his hand and said, we have to do this for you because we're going to help you. But it's not going to feel good when we put that tube back in. I'm going to give you some sedation, but when you wake up, you'll have that old tube back, just like you had after surgery. You're going to have to work with us on this because I'm going to need you to cough and let us pound on your back and do all those things we need to clear out all these secretions that are blocking your breathing. But it's all for you. We're all here for you. We're going to take care of you. So don't feel like this is some kind of something to make you feel bad. It's something to make you feel better. But before we do that, it's going to be uncomfortable with this tube down your throat. But I am going to make sure you're as comfortable as you can be. And so will all of these folks here in the unit. Don't worry. And she spent some time. Okay, so then she did the sedation, put the tube in. Then she brought the family in and talked to them and explained to them why he had the breathing tube back because he'd come out intubated and then been extubated already. She explained his severe lung disease is a problem, and sometimes this happens, but it's nothing that we can't cope with. We've got a tube back in. It lets us to get all the secretions out. We will. He's going to be okay. And again, so impressive. In the midst of all this critical care and all this physiology and the blood gases, and you get the chest x-ray to make sure the tube's in the right place, checking the breath sounds, watching the blood pressure and all that. The CRNA is taking time to be very humanistic, excuse me, with the family and with the patient about what needs to be done, why, what the benefits are, and how we're all there to help. So I hope you guys understand how important that is to being a nurse. You're not just a nurse to do the medicines and the figures and, put the lines in and, do all that. You're also a nurse there to take care of people and to be there for them. And these were all lessons that I've, really helped me to learn along the way. And so anyway, I knew that was what I wanted to do. So I applied to CRNA school and I got into CRNA school. Well, back in 1979, 1980, when I got into school, there was a CRNA program here. It was not in the School of Nursing where it would be today. Instead, it was in School of Medicine because back then, nurse anesthesia was considered to be more related to medicine than to nursing. And of course, we all know now it's a specialty in nursing. But we were figuring all that out back then. So in any event, we had a school through the School of Medicine at UCLA, through the Department of Anesthesiology. And we nurse anesthetist students trained right alongside the anesthesia residents. We did everything they did. We were on call the same way they were. We basically took the same calls, had all the same experiences. So we learned just like one of the medical residents. And again, it was an amazing learning experience for me. I felt like the biggest change as I got into the CRNA role rather than the registered nursing role was that now I was really responsible for writing orders for PACU nurses and for pre-op nurses rather than taking orders and following a sheet of orders. And even though I was working with an attending anesthesiologist who was supervising me in the operating room, the relationship was not where I had a sheet of orders that that physician had written for me to follow. The relationship is all verbal, and it's all the anesthesiologist expecting that I, as a highly trained specialist nurse in anesthesia, I know how to give all the medications. I know how to do all the treatments. He's just there to help if I need help. And basically, what he does is advise me. I think for this case, for example, I think for this case, we probably need to use a lot of narcotic because this patient has a very big drinking history. So if I were you, Chuck, I'd plan to have quite a few ampules of fentanyl on board because I think you're going to need it. So call me if you need me, and then he'd be gone. And the rest of it's up to me. Okay, I've got all these ampules of fentanyl. What do I do? And he expects me to know what to do, not to have to write an order. Oh, give 50 micrograms of fentanyl if the patient complains of pain. No, it's not that kind of relationship. When you're an APRN, you're expected to already have a body of medical knowledge that you can follow. And your physician associates can help you, but you take responsibility for your own actions. And again, as a registered nurse, you also do the same thing. Excuse me. But as a registered nurse, you also usually have a sheet of orders that's guiding you, and you have more of a template to follow upon which to base your nursing judgment and from which to take, what the care plan is going to be for the patient. When you're an APRN, a lot of those orders that were written for you are now being written by you for a patient based on your advanced practice training. And that's what I discovered, I think, was the biggest difference between registered nursing and advanced registered nursing, APRN role, was added responsibility and an added sense that that I needed a body of knowledge that I really hadn't had, so I could function more independently. Even when functioning with my physician colleagues, I still had a lot of independence because they rely on us to really know what's going on. They're just going to give us general advice. Does that make sense to you guys? So yeah, so it was a wonderful experience. I had a great time in school. I learned a tremendous amount. I learned more about medicine in those 2 years than I had learned probably in all of nursing school before. So then there were years when I was working for the UCLA Department of Anesthesiology as a CRNA. And I was first a nurse anesthetist, and then the division above that is senior nurse anesthetist, and I worked all shifts. We had, when I started working, we had a 7 to 3 shift, a 3 to 11 shift, and 11 to 7 shift. And it was only later on when all of nursing went to 12 hours that we went to 12 hours in the OR. But even with their 12-hour shifts in the OR, we still kept 4-hour and 10-hour shifts because we needed those at busy times for the operating room. So I worked all the shifts. We still had a school at that point here at UCLA, the School of Medicine. And so I became a clinical instructor for our students, which again, now I had to really learn more about the role of teaching people. And as registered nurses, you're always going to be responsible for teaching your patients and teaching the families of those patients. But it's a different kind of role when you teach people that are actually in medicine and nursing yourself. And again, as a registered nurse, this is something that you will be doing as a preceptor. If you're a senior nurse on the floor, you're going to precept starting nurses that are just starting out. You're also liable to be clinical instructors for nursing students that are rotating through your unit and learning to be nurses. Like I worked on 5 East at Tampa General for a whole year on nights when I first graduated from nursing school to get my floor experience. But if there had been nursing students, I would have been helping them. The only reason why I didn't work with nursing students at that point is because I worked the night shift, and we didn't have any nursing students at that point that were on the night shift. But you guys will undoubtedly be doing instruction and teaching of a lot of different kinds. And what I would recommend that you do, and for everybody online as well, sorry, I don't mean to ignore you guys online, is I would, as you are continuing your nursing education, I would get, if you haven't already, some references on how to teach clinically. There's a lot of stuff out there now that we all have access to Google AI and probably Chat GPT, who knows what all else. Ask Chat GPT to write you an article about clinical instruction, with the latest references, and then learn from it. because you're going to be doing it. We all always do in nursing. I had to learn it from the ground up because I had never been a clinical instructor before. And what was the most important thing for me was learning how to be kind to people whenever they make mistakes, as students will, and at the same time continue to teach them effectively. But at the same time, give them direction, let them know where they've made a mistake, but more in a constructive way, rather than attacking them for doing something that's not desirable. My student nurse anesthetist got me into all kinds of trouble, of course, as I was working with them and learning how to be an instructor. And thank goodness at that point I was a more experienced CRNA and knew how to get us out of trouble. But I would just warn you that when you do start doing clinical instruction and preceptoring, the people that are learning from you will think of ways to get you in trouble that you would never think of yourself in a million years. So just be prepared and learn a lot of different ways to back out of a situation that someone's gotten you into that you never thought you'd see in your life, but there it is. Yes, so clinical instructor. Oh, and then, yeah, I also started doing other teaching too. I started doing lectures because I really loved it. I love teaching. And as you guys can tell, I mean, here I am talking to you now after all these years. I'm still teaching here in the school and teaching over at USC. So I love teaching. And I also started working for some continuing education companies, which flew me all over the country. That was kind of the fun thing. I was all over the country doing these continuing education lectures for nurse anesthetists, and I loved it. I had a great time. I advanced to become the chief CRNA in 2000. And periodically, I would decrease my hours at Westwood and work part-time at Harbor, UCLA Medical Center in OB, as I really love the OB population. And also over at West LA VA across the freeway because a special spot for the veterans because I have veterans in my family and loved helping working with them as well. Um, and yeah, OB. Have you guys had a chance to have your OB rotations yet? Anybody? It's a special place. It can be the happiest place on earth until it's not. It's the happiest place on earth over and over and over again because, it's a new life, a new beginning for people, a new family. And in so many ways, people are changing their station in life drastically, especially if it's the first time child for them. But you also find out that when there's a bad baby or something goes wrong and you lose a baby or lose the mom or lose both, there's nothing sadder. I mean, it's just an unbelievable, devastating loss to lose relatively young people like that, which can happen, of course, because there would be like any other medical experience, has its share of potential complications and problems, some of which can be deadly. And so I loved my OB work in anesthesia. Um, the women all love you when you're a nurse anesthetist because you're going to put their epidural in. So when you come in the door, they're very happy to see you. They gladly roll over on their side and let you stick that needle in. As a matter of fact, they can't wait. And they're extremely happy. They love you. They offer you all kinds of things. They offer you rewards. They offer you money. They offer you their house, their home, their belongings if you can just get the epidural in. So that was rewarding. And also, they hate their husbands. I can say that too. As much as they loved me, they hated him, and they were like, I never want to see you again, but I love you. Run on in, the epidural. And just learned a tremendous amount again about human beings and at some of their most vulnerable moments. I think that one of the things that some of you might really enjoy about OB is you're taking care again of people at their most vulnerable and their most transformational. I mean, it's a transformational moment for people when you become a parent, even when you've already been a parent and you're becoming a parent again. It's always an amazing trip. So OB is amazing. The vets, on the other hand, amazing. I love them. That was where I had my final clinical job after I retired from my CRNA job at UCLA. I worked until 2021 across the freeway there as a nurse anesthetist again, and just love taking care of the vets. An amazing group of people that have done amazing service for all of us and for this country that you really cannot put a dollar value on. And you have to be around them to really understand them. They're a special population. And just really loved working with them and learned so much from them and about how life can affect people. I learned how battle, for example, being in battle and being in war can cause PTSD for people, post-traumatic stress disorder. I learned about that, and I learned that when I had a vet that I was putting to sleep for surgery who had a history of PTSD, we needed special work with that vet because when that vet woke up, he or she might think they were back in battle again because of the PTSD history. And so what we would do is we nurse anesthetists put together an entire program for our vets that we knew that had PTSD. For each vet that we knew, every time we would take care of a new vet, we would come up with a care plan for that vet, and we had it in the department um, EMR so that we could look it up because every vet needed a particular kind of care or a particular package of medications to successfully wake up, go to sleep, and wake up from the anesthesia and still feel in control and feel like they were safe. And so for every vet, we had carefully, would research them, trying different meds that had worked before. And the problem would not be so much when they were the problems were 2 points. It was when we were trying to get them to sleep because they were scared to death a lot of times of becoming unconscious and losing control. And sometimes what we would do is we would do the induction with a significant other in the room, in the operating room, with their gown and gloves and mask and hair protection on, holding the person's hand so that they felt okay while we were doing the induction of anesthesia. And when they woke up, we had a package of sedative medications and treatments that we would do. For some of them, it was very important not to touch them when they woke up and to give a certain kind of sedative. And when they woke up in the PACU, to make sure the PACU nurses who were in line with our treatment plan for all the patients, because our patients, the treatment started in the pre-op area, went through inside surgery, and then continued into the PACU. We made sure to educate the PACU nurses carefully with classes on what each vet needed, and then they were right on board with that. And sometimes we wouldn't touch them until they actually started stirring. And then we would have their significant other at the bedside that would begin uttering safe phrases and safe words. You're safe. I'm here. It's not happening. We're here. It's okay. Whatever the vet needed to hear. So it was amazing. It was amazing work to do. And I felt very honored to be a part of that and to be able to provide that service to these people that have been of such service to all of us. Let's see. So then in the year 2000, things began to change for me in that I had been a CRNA for some time and been the chief for some time. And I began to be interested in pain as a phenomenon, as something that human beings experience. And so I decided that I wanted to get involved with pain research. So I started helping the docs in the department, especially in the UCLA Pain Service Division, with some of their research. And I told them I would love to be involved. And they basically told me, if you want to do that, go to the School of Nursing and get a PhD, and then you can help us. So that's what I did. So I applied for the School of Nursing. I got in and started doing my research. Started doing my dissertation research on pain in the school, so that I could join them. I found a wonderful mentor here at the School of Nursing, a former professor here named Peggy Compton, who's now one of the deans at University of Pennsylvania, UPenn in Pittsburgh, and with whom I'm still in touch. She was the chair of my dissertation committee, and we designed a program of pain research. But one of the main reasons why I did my PhD work, I was all set to go, but I just couldn't make myself enroll, because you know how life is when you go back to school. Would any of you guys say that going back to school is kind of a disruptor of your life? What do you think? Has it disrupted your life at all, or is it just wonderful? Would you just like to be here forever, paying all this money and not having any time and studying all the time and never sure what you're going to make on the next test? Wouldn't you love that? Yeah, it's a little bit of a disruptor, wouldn't you say? Yeah, yeah. So I didn't want to enroll. I was all ready and I knew what I wanted to do, but I couldn't make myself do it. So I had a patient, of course. I had Iris M. Iris was a patient that I first encountered entirely by accident in our pre-op area when she had a lump in her breast. And my assignment for the day, I was in the breast OR room, where we were doing breast cancer surgery. And my assignment for her was just to do sedation while the surgeons under local removed the lump for pathology. So I bonded with her and her family. They were just such lovely people. We met out in the pre-op area and had a wonderful bonding experience together, and it was amazing. And they liked me, I liked them, I loved her. It was tremendous. I thought, okay, great. Another wonderful patient notch to put on my nursing belt. So about 6 months later, I got a call from the doctor running the OR board saying, "Well, Chuck, one of your patients, Iris Sim, is back, and she wants you. Um, her cancer's come back, and now she has to have a mastectomy, so they want you to take care of her." And I was like, "Okay, well, change the schedule around." And of course, at that point, since I was the chief, I was able to just schedule myself for the surgery center, and we did an outpatient partial mastectomy for her with some lymph nodes. And again, lovely experience, lovely family, glad to see me. Oh, I'm so glad you're here, Chuck. Oh my God, I feel so much better now. And I was like, Iris, you're going to be fine. We'll take good care of you. They'll get all these lymph nodes out. It's going to be fine, yada, yada, yada. So, did the surgery. 6 months later, another phone call. Chuck, this patient, Iris M, is back again. Well, this time, the cancer is all over the place. It's come back. It's in her lungs. It's in her bones. And now they have to put in a line for chemo, and she wants you. And I was like, oh, okay. So this surgery much different, now because again, it's just sedation, but now we're putting this line in for chemo for someone who's probably going to die. So a very different scenario. The way you have to approach this as a nurse is you can't go in there all bubbly and sunshiny and saying, oh, everything's going to be fine. We're going to take this lesion out. You're going to be great. It's going to be good. You go in there quietly and you say to the patient, okay, I'm here. Let's get this done. We're going to take good care of you. Everybody's on your side. I just want you to know that. Not giving them any false hope or anything, but just letting them know we're here from the beginning and we're here to the end for you. And so yeah, so we did the surgery. We got the line in, and she was having her chemo. And about probably 3 or 4 months later, um, a floor nurse at UCLA called me and said, "I've got this patient, Iris Ann. She wants you to come up," because I was in the operating room at the time. "She wants you to come up and talk to her." And the nurse said, "She just says she has a message for you. She's pretty much terminal, and she's on high doses of Dilaudid, but she's still with it enough to know what's going on, and she wants you. So you get your butt up here to talk to her because I told her you were coming." And I'm like, all right, I'm coming. I just have to finish up my cases." So I finished up my cases for the day, and then I traced myself up to where was it? Um, 8 East or wherever, and there she was on the floor, and she had her dilaudid infusion going, and skinny as a rail, and obviously not long for this earth. And she grabbed my hand with her hand, and she said, "You got to go back to school, and you got to do something about this dying with pain business, mister. You've been talking about going back to school. Now you're going to go." And I was like, okay, I think I'm getting a message here. So the next day, I enrolled myself in the UCLA PhD in nursing program. I thought, I think I got a message. I think I should do this. I think I got a message maybe from almost beyond the grave. I should do this. And later on, I was invited to speak at her funeral. And when I did my bit, I told them I was going to school, and they were all like, "You should go. She wanted you to go years ago." And I was like, "Okay, I'm going. I'm going." So anyway, I was in school. That was the reason why I actually got into school. But I thought you guys would enjoy that story again. It's part of nursing. It's part of what we all do for a living. It's taking care of these people in every stage of their life. So anyway, I did my project. I found a wonderful mentor, Peggy Compton, very physiology based, and we did the effective pain on leukocyte cellular adhesion molecules. What we did is we looked to see if pain could actually cause an inflammatory response itself by stimulating immune cells to become more inflammatory. And we found that it actually could. We actually we know that inflammation causes pain. You guys know when something gets infected, it's going to hurt, right? Because the little inflammatory mediators have turned up your pain nerves. But did you know when you have pain somewhere, it can also cause some inflammation in your body? I didn't know that. We were just learning that in the pain community back in the mid 2000s, early 2000s when I was finishing up my dissertation. And it's my pleasure to be involved with these people that were on the cutting edge and to contribute my work showing that yes, pain can actually cause this inflammatory condition because we had not known that before. Now, of course, we know there's a bidirectional communication and all the fancy pain communication pathways, which I know about, and I'm not going to bore you with. But I know about them now because I learned them as part of my PhD work. And so anyway, I did a number of different pain studies with the pain team, including this one, and we had a great time all working together for sure. And it was just great. My becoming a nurse scientist, I would just say to you guys that this was kind of a um, it was a brand new part of nursing for me because when you're a bedside nurse and when you're a nurse specialist, you're focused. I'm sorry, you guys, I have this stupid sinus infection. When you're a bedside nurse or a nurse specialist, you're focused on your patients, and rightly so. Thank goodness we have bedside nurses, right? Thank goodness we have nurse specialists to take care of us and our families when we're sick. When you become a nurse scientist, though, the view of your world widens up. You really begin to look at nursing as an entire profession and its impact on the world. When we were doing those pain studies that we did, we looked at what the impact might be on the pain treatment for chronic and acute pain patients everywhere. And it did move the needle in a lot of different ways. The work that I did is just part of this big team. And so many of my mentors at UCLA, Department of Anesthesiology, Pain Service, all of us really moved the needle by the research that we did. We designed these clinical studies exploring pain. We identified the aspects of how pain and the immune system interacted, trying to figure out if there was some way to alter things such that pain would be even better. We could take care of pain more efficaciously. And along the way, I became Dr. Griffis because I got my PhD. Well, this caused a little bit of consternation in my department. Now, I had always been Mr. Griffis or Chuck, which is fine. I was a nurse anesthetist and happy to be a CRNA. Always introduced myself as Mr. Chuck Griffis, your CRNA for the day. Or you can call me Chuck, or you can call me, nurse anesthetist, whatever you want to call me. But never doctor because I didn't have a doctorate degree. So when I got my PhD, it caused a little bit of a wave in the department. I was the first CRNA that ever had a doctoral degree in our department. And so the doctors were all like, well, what should we call you? And I was like, well, I don't know. You can call me whatever you want. I don't care. I said, but why not doctor? I said, as a joke, I said, why not call me Dr. Nurse? Well, they love that. So from then on, I was Dr. Nurse. Oh, this is your Dr. Nurse. This is your Dr. Nurse anesthetist here who's going to take care of you today, they would say to the patient. I was fine with that. I also, however, as I continued to do more, excuse me, excuse me, as I continued to do more studies with our pain service, I also rose in academic rank. Now, academic rank, you guys, those are professorships. And you have assistant, you have associate, and then you have full professor. And most of the folks that train you guys are the assistant or associate professor level. And so I rose to the associate professor of anesthesiology level. And that put me at a higher rank than some of the younger physicians that were supervising me in the operating room. So that always made for an interesting interaction, because especially patients that knew what academic rank meant. I had it on my name tag, at that point. Right now, I'm an assistant clinical professor here because I'm retired and I've come back. But then I was an associate professor of anesthesiology. So I would come into the cubicle as the nurse anesthetist, happy to be the CRNA, and my young attending would be with me. And he would be an assistant professor and I would be an associate professor. And the professor on the table that was our patient would look from one to the other and say, interesting, who's in charge here? And I would say something like, well, that's always the question, isn't it? And I would look at my young staff, and my young staff would usually say, he's always in charge, and just laugh. But it made for some interesting conversations. But yeah, it was really great to be able to look at nursing in a new and different way as a scientist now. But when I gave my address at the graduation, excuse me, for the 2005 class of PhD students, basically what I said to everybody was, even though I'm a nurse scientist, I never left my patients. I haven't left my patients' bedside. I'm still here to take care of them. It's just that I can take care of them in a different way now. I can actually look at more of the how things work behind instead of just what exactly we're going to do. I can look at what underlies what we're doing and maybe how to improve it better than I was ever able to do as a bedside nurse. It's just a different role. But I said, we're all in this together. When I was doing this address for the graduating 2005 class, we had Meccans, we had BSNs, we had MSNs, and we had PhDs. And I told everybody, I said, we all have to work together because if we don't work together, we can't take care of the patients that are going to be presented to us to take care of. We're all in a big team together. And I still believe that. Let's see. So then, as the years continued to pass and I continued to gain more wrinkles, each one of which I earned, I believe, I joined the California Association of Nurse Anesthetists, of course, and the American Nurses Association, California, ANAC. And I began learning about advocacy and politics and legislators. Because now I had quite this background, as a nurse specialist as well as a nurse with a PhD. I had quite a background. So when I could go and talk to legislators about why they should do this or that piece of legislation to help our patients, they would really listen to me a lot because they knew that I knew what I was talking about. I was somebody that understood pain, somebody that understood, how the profession works and how nurses are needed and how they're used. And so I began to be a pretty effective lobbyer. I always hated the idea of lobbying in the past. I had never really, until the mid 2000s, after I was done with my PhD, I never was, excuse me, really very active in my state association or my national association because I just thought, oh, I don't want to do that. And by the way, how long can we talk? Are we here until
An hour.
Okay, so we're here until one?
Yep.
Okay, just want to know. So I thought to myself, I don't want to do that. That's boring. Who wants to go in there in a room full of these legislative people? They don't even know who nurses are. I have to start from scratch, explain what I do. This is really stupid. I don't want to do that. Of course, at the time, I didn't realize that my ability to practice nurse anesthesia depended on the legislation that these legislators were writing. That your ability to function as registered nurses is going to depend on the Nursing Practice Act, which is soon going to be open for revision. I didn't realize any of that. And I began to learn that because I got a lot of pressure on me to step up and to help, instead of just being in an ivory tower and doing my research on my own and publishing, use it for something. So after a lot of trepidation, about 2008, I joined CANA, the California Association, and ANA, and that was that, boy. As soon as I joined, I began learning about all this stuff, like you should step up whenever there's a bill that's important for patients. Where's your voice? What are you going to do? You can help so many people. You can't just help, you're not just helping the patient in front of you, you're helping a lot of patients. And I was like, oh, really? I didn't know that. So I really began learning all that stuff. So I began joining committees, as one does, both in ANA and CANA. And I became the president of the California Association of Nurse Anesthetists, 2015, and not through 26, through 16, that should be. I was there for 2 years. And I began visiting Sacramento and giving testimony on bills and really doing a lot of lobbying because I really got to know all of my people. I began paying AANA lobbying visits to Washington, D.C. every year. The American Association of Nurse Anesthesiology, which is our national organization for my nursing specialty, has an entire week of lobbying, just like ANA does, American Nurses Association does, and AMA, American Medical Association does. They have an entire week of lobbying where all of us from California, from Washington, from Oregon, from Idaho, from Massachusetts, from New York, from everywhere, go and visit our legislators in the Capitol, in their offices, and lobby for national legislation. And I learned to do that. I learned to lead a team doing that, doing it year after year after year. I learned how to navigate the unbelievably, incredibly challenging subway for Washington. And I grew to love it. And so I did many lobbying visits, and to me, it was just after a while, it was just something that I was born to do because I really knew how to tell the story, get them on our side, and get their votes. And so it was just amazing. And I came back and I began doing classes at the program of nurse anesthesia at USC. That's where our UCLA program moved to back in the 80s. It moved over to USC. I began going over there and doing classes for them and also doing classes for ANA and doing webinars for ANA on lobbying and advocacy. And I really became a team leader and learned so much. So what I would tell all of you guys here and everybody online too, really, really, not like me. Don't wait until you're later in your career. Get involved with lobbying and advocacy for your career, for nursing, and for your patients early on, because you can make such an impact. Such an impact. It's amazing if you just will step up. It doesn't take that much time and effort to do. Um, Now I know my state legislators on a first name basis. My senator is Lola Smallwood Cuevas, and I have my assembly person, my assembly member, excuse me, is Isaac Bryan. I go to all of their local events here. I go to their local offices here. I talk to them about important bills in Sacramento at the state level. I just got through on the 22nd of November doing a turkey giveaway for Isaac Bryan's office. You can go whenever you need to. Don't worry. Yeah, you go. No problem. No problem. Here, walk around this way. No problem. Have a good day. Just on the 22nd of November, I went to the turkey giveaway for Isaac Bryan's office. And at these events, I don't necessarily do any health care. I don't necessarily do direct nursing care. What I do is I set up tables, I pass out literature, I take people around to the different tables where there's different services offered for them, like Medicaid, learning about Medicare and learning about Medi-Cal, the different nonprofits that offer healthcare in the neighborhood. I take them around, I give out the flyers. If anybody has a particular healthcare question, I always wear this name tag so they know I'm a nurse and they know where I'm from here. And I will answer any health question I can from them, including, I think you should see your physician about that, if it's out of something that I can't tell them as a nurse. And so it's an amazing collaboration with these legislators. I go to all their local events and I have learned so much and they love me. This office staff loves me now because I help them so much. I come early, I stay late, I help set up, I help tear down. I'm out there talking to all the people, I coordinate the event, and it just so happens that I'm also a nurse. So later on, when it's time for me to come to them with a bill, like I just did with AB 876, that I need them to vote on for us, they're like, okay, well, I know you. You work for us, right? You're a volunteer. Yeah, I do. I'm a nurse. I help all the people at your events. I help set up. I help tear down. I love your events. I love what you're doing in the neighborhood. Let's talk about this legislation. I need your help now, like I've been helping you. And although I'm not expecting them necessarily to vote for my legislation, I'd like them to, but I'm not expecting them to. I do expect them then to listen to me because we have a relationship. And this relationship is so important and it's really makes them listen. And we just got the nurse anesthetist in California, just got a huge piece of very helpful legislation for our practice passed. And in part, it was because of people like me working with these state level legislators and letting them know we're here to help you. So when we need you, listen to us and you can learn from us. All right, you guys. So at the present, I'm kind of retired from clinical practice. I'm a visiting lecturer. I lecture here at the school extensively. I teach in the APN, acute care nurse practitioner program here. I also lecture for the DNP program here. And of course, I actually am on the faculty for the USC program for nurse anesthetists. I'm now researching wellness and suicide prevention. We are working now on putting together a suicide prevention video for our nurse anesthetist students. And we're hoping that we're going to be done with that by the middle of this coming year. We're just now getting all the contracts in place for the video production company, but it's going to be a national video targeting these particular nursing students as they do their advanced practice education with all the stresses and strains that we all undergo. Because suicide is a big problem for all of us in healthcare. We have an elevated rate as compared to the general population. And who's surprised? What we're doing for a living can be very challenging indeed. And so we need the wellness research. We need the wellness work, which I'm now a big part of. I'm not doing pain work anymore now, although I still consult for the pain studies. I do a lot of committee service for my national association. I'm on the editorial panel for our journal. I'm also the chair of our infection control panel. I do classroom and research teaching for, again, our nurse anesthesia program. Again, I teach in our acute care nurse practitioner program here at UCLA and love it. Wouldn't give it up for anything. So I would say in conclusion, you guys, that it's just been a wonderful trip. Nursing is just amazing. Now it will drive you to the brink. because it's very challenging. But I hope you guys at least had an idea of what you were signing up for when you got into school. It's not easy, it's hard, it's challenging, but the rewards, there's really nothing like it. When a patient comes to you and takes your hand and says, "You were there for me when nobody else was. You were there for me in a way nobody else was. Without you, I wouldn't be here. Thank you so, so much." There's just nothing like that for an affirmation in your life. So, from great challenge also comes great reward. So I would just say to you guys, I think that you're in a wonderful profession. It's been wonderful for me, and I am happy to be your colleague in this profession for the years ahead. So thank you all.
Yay! Thank you, Dr. Griffin. Woo! That was great. Woo! Thank you, everyone, for joining us today. We're gonna go ahead and close out. Thank you for your participation. Thank you again, Dr. Griffiths.
Sure, my
Bye,
pleasure, you
everyone.
guys.